You know that feeling. It's specific, it's visceral. It's the hallway outside the exam room.
Mm-hmm.
The air conditioning is humming a little too loud, your palms are clammy, and you're clutching a stack of short notes you've read 1,000 times but suddenly feel like you've never seen before in your life. You're about to walk in for the MD Anesthesiology final viva.
That is a setting that induces a very specific type of physiological tachycardia in even the most seasoned residents.
Right.
It is the moment where theory meets the terrified reality of what would you actually do?
Exactly. And today on the deep dive, we aren't just chatting casually. We are simulating that walk into the lion's den. We're treating this session as a final high-yield revision with a senior faculty member that's you getting our listeners ready to face the rigorous standards of the Gujarat University examiners.
An excellent goal. And knowing those standards, we aren't going to waste time on the basics of, say, an appendectomy. We need to talk about the cases that fail candidates.
Which brings us to the topic on the table: neonatal gastrointestinal surgical emergencies. Specifically, the two giants, Hirschsprung disease and necrotizing enterocolitis, or NEC.
The big two.
Now, I've got the stack of papers here. We're looking at Robbins for pathology, Miller and Morgan for the anesthetic management, and even some specific surgical insights. But looking at this, my first question is, why these two? Why do examiners love them so much?
Because they are the ultimate filter. If I ask you about an inguinal hernia, I'm testing a procedure. But if I ask you about Hirschsprung or NEC, I'm not just testing your knowledge of a disease.
You're testing everything.
I'm testing your grasp of neonatal physiology, your understanding of fluid mechanics in a septic model, your ability to manage a difficult airway under pressure, and your competence in handling sepsis. It requires a multidisciplinary mindset.
Right.
You cannot just be the technician putting the tube in. You have to be the perioperative physician.
Right. Shifting that whole narrative from putting the baby to sleep to, keeping the baby alive while the surgeon works.
Precisely. In the exam, especially at the MD level in Gujarat, we are looking for safety. We want to know that you understand the high-risk nature of these conditions, the sepsis, the massive fluid shifts, the temperature regulation issues.
So it's about the whole picture.
The whole picture. Whether it's a theory paper-long question, a short note, or a Viva table trap, these topics distinguish the safe anesthesiologist from the dangerous one.
Okay, let's get into the exam hall mindset then. We're going to break this down logically, just like a long answer structure. We'll start with Hirschsprung, move to NEC, then look at the anesthetic management for both, and finally we'll do a side-by-side comparison to help you answer those tricky Viva questions.
Sounds like a plan.
So Part B, Hirschsprung disease. Let's start with the definition. If I'm sitting across from the external examiner and I say it's a condition causing constipation, I'm failing, aren't I?
You're not just failing, you're being politely asked to leave the chair. That is a layperson's definition. The examiner wants precise pathological terminology. The definition you need to anchor your answer on is congenital aganglionic megacolon.
Congenital aganglionic megacolon.
And the key clinical phrase you must use is functional intestinal obstruction.
Functional intestinal obstruction. Okay, let's unpack that word functional. Why is that the distinction?
Because there is no physical barrier initially. It's not like a tumor blocking the pipe or a volvulus twisting it shut. The obstruction is caused because the bowel literally cannot function. It stems from a specific failure during fetal development.
And this brings us immediately to the embryology. I feel like we often gloss over this, but to really understand the disease, we have to understand the journey of the neural crest cells.
Absolutely. This is the marathon analogy. During fetal development, specifically weeks 5 through 12, neural crest cells migrate from the neural tube down to the gut to form the enteric nervous system.
Okay.
They start at the vagal level, the top, and they have to migrate all the way down the gut tube from the esophagus to the anus.
So it's a long road, a craniocaudal migration.
Exactly. It's a very long road, and they are forming two specific networks as they go. The Meissner plexus and the submucosa, which, handles secretion and blood flow, and the Auerbach plexus in the myenteric layer, which handles motility.
So in Hirschsprung disease, the runners don't finish the race?
Correct. The migration process arrests. It stops prematurely. And since the cells migrate from head to tail, the segment that is missed is always the most distal part. The rectum is the finish line, and they didn't make it.
Which explains why the rectum is always involved.
Always. The rectosigmoid region is the most common site. That's about 80% of cases. But in rare, severe cases, you can have total colonic aganglionosis, where the entire colon is devoid of these nerve cells because the migration stopped way back at the ileum.
Wow, so the whole colon just doesn't work.
A whole colon is aganglionic. It's a devastating condition.
And for the genetics buffs out there, or for the student looking for that gold star in the Viva, this is where we drop the RET proto-oncogene, right?
Yes. If you want to impress the examiner, you mention the RET gene. Heterozygous loss-of-function mutations in the RET gene are the most common genetic alteration associated with this.
And what does that gene do?
It's the gene responsible for the signaling that keeps these cells alive and moving. So if the signal fails, the cells undergo apoptosis. They die before they reach the rectum. Mentioning the RET gene shows you have read the pathology texts like Robbins thoroughly.
Okay, so we have a segment of bowel, the rectum, that has no nerves. Now, intuitively, if I cut the nerves to a muscle in my arm, it goes flaccid, it goes limp. But in Hirschsprung, the aganglionic segment is contracted. It's tight. Why?
This is the exam gold concept regarding pathophysiology. This is probably the most common point of confusion. You have to remember what the enteric nervous system actually does. A huge part of its role is inhibitory.
Inhibitory.
Yes. It provides the signals mediated by nitric oxide that allow the smooth muscle to relax and let stool pass. It's the open the gate signal.
So without the nerves, there is no relaxed command.
Exactly. The default state of the smooth muscle is tonic contraction. It's just sitting there squeezed tight. Without the ganglia to inhibit it, that segment is permanently spasmed.
I see.
Pathology texts often describe it as having the inflexibility of a rubber hose. It's narrow, stiff, and unyielding.
And meanwhile, upstream, the normal colon, which has nerves, is fighting against this closed door.
And failing. So over time, that proximal healthy bowel dilates massively. It fills with gas and impacted feces. That is why it's called megacolon.
Ah, so the megacolon is actually the healthy part.
That's the key insight. The megacolon is the normal innervated bowel that is trying to compensate for the sick, narrow aganglionic part downstream. The pathology is distal to the dilatation.
And this leads to the dreaded complication, the one that turns this from a scheduled surgery into a septic nightmare.
Hirschsprung-associated Enterocolitis, or HAEC.
What exactly is happening there?
It's stasis. Simple as that. Stasis of stool leads to bacterial overgrowth. The bacteria, especially Clostridium difficile, proliferate. The mucosal barrier breaks down, and you get translocation of bacteria into the bloodstream. Now, you don't just have a blocked bowel, you have sepsis.
And that changes everything from an anesthetic point of view.
It changes everything. And from an anesthetic perspective, that massive abdominal distension has to be a nightmare for breathing.
I was just about to ask about that.
It is. Remember your neonatal physiology. They are diaphragm-dependent breathers. Their ribs are horizontal and pliable. The intercostal muscles are weak. They rely almost entirely on the diaphragm moving down to breathe. If you have a massive megacolon pushing up, splinting the diaphragm, the functional residual capacity, FRC, is decimated. They have no reserve. They desaturate instantly on induction.
Okay, let's move to clinical features and diagnosis. How does this baby present?
The classic history in a neonate is failure to pass meconium in the first 24 to 48 hours. Any full-term neonate who hasn't passed stool by day 2 needs a workup for Hirschsprungs. That's a red flag.
And in older infants?
In older infants, it presents as chronic constipation, failure to thrive, and a distended belly. They might have a history of requiring enemas or suppositories just to have a bowel movement.
And there's a very specific physical sign mentioned in the surgical manuals, specifically regarding the rectal examination.
The toothpaste stool, or sometimes called the Squirt sign.
It's such a vivid description. Walk us through it.
When you do a digital rectal exam, the rectum feels empty and tight because the stool can't get into that spastic segment. But when you withdraw your finger, you momentarily dilate that sphincter and release the spasm.
So it's like opening the floodgates.
For a second, yes. The gas and liquid stool that was backed up under pressure explodes out like toothpaste being squeezed from a tube. It's messy, but it's highly suggestive of the diagnosis.
Speaking of diagnosis, if we are in the exam, what is the gold standard?
Rectal biopsy, no question. You must demonstrate the absence of ganglion cells in the submucosa and myenteric plexus.
What are you looking for exactly?
You're looking for what's not there. The pathologist will stain the tissue, often with acetylcholine esterase staining, and they're looking for the ganglion cells. You might also see hypertrophied nerve trunks, thick nerves trying to find their target, but failing, but no ganglion cells. That's diagnostic.
And the barium enema? Is that still done?
It's a useful tool, yes. It gives you the visual map. You see a narrow distal segment, the aganglionic part, and a funnel-shaped transition zone leading into the dilated proximal megacolon. That transition zone is the hallmark on imaging.
Okay, so we have a diagnosis. Now we're moving toward the operating theater. This is part 5, preoperative management. Is this a surgical emergency?
This is a common trap. Generally, no. Hirschsprung disease is a medical urgency, not a surgical emergency, unless there's a perforation.
So rushing to the OT is the wrong answer.
Rushing to the OT is the wrong answer. You do not rush this child to the table at 2 a.m. usually. You optimize them. Optimization is the key word.
How are we doing?
Decompression. First and foremost, we use rectal irrigations or saline washouts to help empty that proximal bowel. We insert a large bore tube past the obstruction and wash it out repeatedly. This relieves the distension, improves the diaphragm excursion, and clears the bacterial load.
And we are fixing the fluid status.
Absolutely. These kids can be severely dehydrated from vomiting or sequestration of fluid in the gut. They can be quite hypovolemic. You need to correct electrolytes, specifically sodium and potassium.
And if they have HAEC?
If they have Enterocolitis, then they are septic. You treat the sepsis with broad-spectrum antibiotics and aggressive fluid resuscitation before you even think about induction. You treat the sepsis first.
Okay, the patient is optimized. We are rolling into the OT. This is part 6. Anesthetic management. This is what the examiner is waiting for.
Yeah.
What are our goals?
The anesthetic goals are clear, and you should state them as such. 1, prevent aspiration. 2, maintain hemodynamic stability. 3, provide a quiet surgical field with muscle relaxation.
Let's talk induction. The stomach is likely full, or at least the intra-abdominal pressure is high?
Always assume a full stomach. Even with washouts, these kids have high pressure. So rapid sequence induction, or RSI, is the standard safety answer. You want to secure that airway fast.
Tube or LMA?
Endotracheal tube, ETT, mandatory. Do not use an LMA in a laparoscopic or open bowel surgery with obstruction risks.
What about mask ventilation?
You have to be very, very careful with mask ventilation before intubation. If you pump air into the stomach, you're making the surgery harder and compromising the lungs further. It's called insufflation.
So you could actually worsen the distension?
You can absolutely worsen it. Gentle cricoid pressure if your institution practices it, but prioritize getting the tube in quickly and safely.
Now, here is a specific question I see coming up in Vivas all the time. Nitrous oxide. Yes or no?
No. Ideally, absolutely not. It's a contraindication.
We need to explain why. It's not enough to just say it's bad. We need to invoke the physics.
You do. You have to explain the science. It's Fick's law of diffusion. This is critical. Nitrous oxide is 34 times more soluble in blood than nitrogen is. Nitrogen is the main gas in room air, and therefore in the gut.
Okay, so it moves much more easily into spaces.
Much more easily. When you turn on the N2O, it rushes out of the blood and into air-filled cavities like the bowel much, much faster than the nitrogen in that cavity can leave.
So if you have a distended loop of bowel, which is essentially a closed air pocket, the N2O floods in.
And the volume expands rapidly. In a closed-loop obstruction, the pressure skyrockets. This does 3 terrible things.
What are they?
1, it compromises the blood supply to the gut wall, increasing the risk of perforation. 2, it splints the diaphragm even further, making ventilation impossible. And 3, it makes the abdomen so tight that the surgeon physically cannot close the fascia at the end of the case.
So N2O is the enemy. Got it. Now, let's pivot to fluids. This is an area where I feel like the textbooks have shifted ground recently. I remember reading older texts that swore by hypotonic fluids for neonates because their kidneys were immature.
That was the dogma for a long time. The 4-2-1 rule, using dextrose 5% with 0.18% or 0.2% saline. But that has changed, and this is where the Miller's update note is vital for your exam.
What changed?
We realized that the surgical stress response causes a massive release of ADH antidiuretic hormone. ADH tells the body to hold on to free water.
Right, the stress response.
If you are pouring in hypotonic fluids, which are full of free water, into a system that is already hoarding water, you dilute the serum sodium rapidly,
Leading to acute hyponatremia.
And in a neonate, that leads to cerebral edema and seizures. It's iatrogenic. We caused it.
So what's the new rule?
So the modern safety consensus, and what you must say in the exam, is that we use balanced salt solutions, isotonic fluids, plasmolite or Ringer's lactate. We treat the neonate sodium just like in adults regarding maintenance during surgery.
What about glucose? Do they still need sugar?
They do, because they have low glycogen stores and are prone to hypoglycemia. But we don't use D-Fi as the main carrier fluid. We run a separate infusion of glucose or use D1, D2 in isotonic fluid, and we check blood sugars regularly.
So you're titrating it.
You're titrating it. We want to avoid hypoglycemia, but we also want to avoid hyperglycemia, which can worsen neurological outcomes if there is any ischemia.
Temperature control. This seems basic, but it's critical.
It's not basic, it's survival. Neonates have a huge surface area to volume ratio and thin skin. They lose heat incredibly rapidly.
And what happens when they get cold?
A cold baby is a baby that won't clot, their drugs won't be metabolized properly, and they won't wake up. Their enzyme systems fail. You need forced air warmers, fluid warmers, a wrapped head, and an increased OT ambient temperature. You should be sweating so the baby is comfortable.
Postoperatively, what are we watching for?
Pain control is huge. A multimodal approach is best to spare opioids because we don't want to stop the gut from moving. Regional techniques like a transversus abdominis plane block or tap block can be very effective.
And complications.
But the big complication to watch for is the anastomotic leak and, surprisingly, enterocolitis.
Wait, even after the surgery?
Yes. HAEC can occur post-op. Just because you remove the aganglionic segment doesn't mean the motility is instantly perfect. They can still get stasis and sepsis. So vigilance is key.
Okay, that covers Hirschsprung. We've established it's a plumbing problem with a risk of infection. Now let's take a breath and switch gears to the other beast. Part C, Necrotizing Enterocolitis, or NEC.
Now we are moving from the pediatric ward to the NICU. If Hirschsprung is a clogged pipe, NEC is a house fire. It is a different animal entirely.
Let's define it for the examiner.
NEC is an acute inflammatory disease of the bowel occurring primarily in premature infants, characterized by ischemic necrosis of the intestinal mucosa, which can progress to full-thickness death of the bowel wall.
Okay, so a lot of key words there. Premature, ischemic, necrosis.
Exactly. It's a disease of immaturity and ischemia.
What are the risk factors? We usually talk about the big three.
First and foremost, prematurity. The gut barrier is immature, the immune system is immature, motility is poor, everything is underdeveloped.
Number 2.
Second, feeding. Specifically, hyperosmolar formula feeding. It provides a substrate for bacteria to ferment, producing gas and inflammatory byproducts. Breast milk is protective.
And third?
And third, ischemic insults. Perinatal asphyxia, patent ductus arteriosus with a left-to-right shunt stealing blood from the gut, or conditions that cause the diving reflex.
The diving reflex, explain that.
It's a survival mechanism. When a fetus or neonate is hypoxic, the body shunts blood to the vital organs, the brain and the heart. To do that, it steals blood from the non-vital organs, the skin, the kidneys, and the gut. So the gut suffers ischemia to save the brain.
So you have a premature gut, you stress it with formula, and you starve it of blood.
And that triggers the vicious cycle. Ischemia leads to mucosal injury. The barrier breaks. Bacteria invade the wall. That causes inflammation, which releases cytokines, which causes more vasoconstriction and ischemia. It just spirals.
So it feeds on itself.
It feeds on itself until you have transmural necrosis. The bowel wall dies completely.
And when the wall dies?
It perforates. You get fecal peritonitis, sepsis, and a massive systemic inflammatory response syndrome, or SIRS. These babies are incredibly sick. This is the most common gastrointestinal emergency in the NICU.
Clinically, what does the nurse see?
The classic triad. Abdominal distension, often the skin looks shiny and tense because it's so swollen. Bilious vomiting or feeding intolerance. And bloody stools, often called hematochezia.
How does this stool differ from Hirschsprung?
In Hirschsprung, the stool is explosive and might not be bloody unless there is enterocolitis. In NEC, the bleeding is due to mucosal sloughing. The lining of the gut is literally dying and falling off.
So there's a different kind of bleeding.
Yes. The stool is mixed with blood and mucus, often described as currant jelly. It implies ischemia.
And systemically, what's happening to the baby as a whole?
They crash. Apnea, bradycardia, temperature instability. Note that septic neonates often get hypothermia, not fever. Their thermoregulatory center is too immature. They become lethargic and acidotic.
Let's talk about the x-ray. There is a pathognomonic sign here, too.
Pneumatosis intestinalis.
Which means?
Gas within the bowel wall itself. The bacteria have invaded the wall and are producing gas. It looks like bubbles or railroad tracks in the wall of the intestine. If you see that, it's NEC.
Maybe it gets worse.
Later, if it perforates, you see the football sign. A large pocket of free air in the peritoneal cavity that outlines the falciform ligament, looking like an American football.
Or portal venous gas.
That's an ominous sign. Gas has traveled from the gut veins up into the liver. It usually implies extensive necrosis and a very poor prognosis.
Okay, so we have a sick septic preemie with NEC, management time. Do we operate immediately?
Not always. We start with medical management. The initial treatment for NEC is medical. NPO bowel rest, decompress the stomach with an orgastric tube, broad-spectrum antibiotics, and aggressive resuscitation.
So surgery is not the first step.
No. But if there is a perforation, a pneumoperitoneum, or clinical deterioration despite maximal medical therapy, they need surgery.
This brings us to section 11, preoperative stabilization. You call this the anesthetist's nightmare.
Why? Because you are not dealing with a patient who simply needs surgery. You are dealing with a patient who is actively dying of septic shock. They are acidotic, coagulopathic, and hypotensive.
And this is an exam trap.
This is a classic exam trap. The examiners love to set it. They will present a baby with free air on the x-ray, the football sign, and ask, what is your next step?
The reflex is to say induction and intubation.
And that is the wrong answer. That baby has a pH of 7.1. They are hypovolemic from massive capillary leak. Their platelets are 20,000. If you push propofol in that state, you will arrest the heart.
So what's the safe answer?
The answer is resuscitation. You must say, my first priority is to stabilize the patient.
It's medical management before surgical management. We are talking about aggressive fluids.
Very aggressive. You cannot be shy. They have massive third space losses due to the capillary leak from sepsis. The peritoneum is acting like a burn weeping fluid. Intravascularly, they are bone dry. You give boluses of 10 to 20 milliliters per kilograms of crystalloid.
And when fluids aren't enough?
Often they aren't. You need inotropes. You need to start a vasopressor infusion.
These are ones.
Dopamine is often the first line in neonates to support renal perfusion and pressure, but in warm shock or severe sepsis, you might need epinephrine. The goal is to maintain mean arterial pressure appropriate for gestational age.
And the metabolic acidosis.
It can be severe, pH of 7.1 or 7.0. You might need bicarbonate, but be very careful. Bicarbonate produces CO2 when it buffers acid. If your ventilation isn't adequate, you'll worsen the intracellular acidosis, so you must have control of the ventilation first.
And platelets, you mentioned that.
Thrombocytopenia is a hallmark of NEC. The platelets are consumed by the sepsis, leading to the IC. You often need to transfuse platelets and fresh frozen plasma, or FFP, before the surgeon makes the incision, or they will just ooze from everywhere.
So we're in the OT, or maybe not.
Good point. Often these babies are too unstable to transport to the main operating theater. We might do the laparotomy right there in the NICU at the bedside.
That adds a whole layer of complexity. No gas scavenging, cramped space, bad lighting.
Exactly. It's a hostile environment. So your anesthetic technique has to be adapted. This is section 12. For induction, forget propofol.
Too much cardiac depression.
Way too much. It will flatline a septic neonate. We rely on a high-dose opioid technique. Fentanyl is the workhorse here.
What kind of dosing are we talking about?
We are talking 10, 20, even up to 30 or 50 micrograms per kilogram.
50. That sounds massive compared to adult dosing.
It is, but neonates in pain and shock tolerate it well for cardiovascular stability. It provides intense analgesia and blunts the stress response without dropping the systemic vascular resistance like volatiles or propofol would.
And you're not worried about apnea?
We aren't worried about respiratory depression because we aren't planning to extubate them for days.
Yeah.
They will remain intubated and ventilated.
What about ketamine?
Ketamine is a great option if they are hypotensive, as it supports the systemic vascular resistance by releasing catecholamines. It's a very hemodynamically stable drug, but often these kids are already intubated in the NICU, so it's not a standard induction. It's more about deepening the anesthesia and paralyzing them.
Muscle relaxation.
Essential. You need a relaxed abdomen for the surgeon, rocuronium or vecuronium. Cisatracurium is a good choice if there is renal or hepatic failure, which is common in sepsis because it has Hoffman degradation.
Ventilation strategy. The abdomen is tight, the lungs are stiff.
It's a battle. The abdominal distension splints the diaphragm, pushing it up. You need higher peak pressures to ventilate, but the lungs might be fragile from prematurity or respiratory distress syndrome.
So what do you do?
You use pressure-controlled ventilation. You accept some hypercapnia if you have to permissive hypercapnia as long as the pH isn't crashing.
Yeah.
You want to avoid barotrauma at all costs.
And fluid management intra-op.
Massive. The peritoneum is inflamed. When the surgeon opens the belly, the evaporation is huge. You need to keep up with third space losses. Blood transfusion is common. Keep the hemoglobin above 10 or 12 to ensure oxygen delivery to the tissues, and watch the glucose.
Hypoglycemia.
Yes, they have low glycogen stores, but also hyperglycemia from the stress response. Both are bad for the brain. You need a glucose infusion running separate from your resuscitation fluids and frequent monitoring.
Hose up. Do we extubate on the table?
Absolutely not. Never. This is a sick abdomen. They go back to the NICU, intubated and ventilated. They will need support for days. Do not be a hero and try to wake them up. Survival is the only metric that matters.
Let's talk about the surgery itself for a moment. It's not always a resection, right?
Yeah.
Sometimes they just put a drain in.
Correct. It's called peritoneal drainage. In extremely low birth weight infants, we're talking under 1,000 grams, who are too unstable for a laparotomy, the surgeon might just make a small incision under local and put a drain in to let the gas and pus out.
A temporizing measure.
It's a bridge to surgery or sometimes definitive treatment if they're lucky. But if they go for a laparotomy, it usually involves resecting the dead bowel and bringing out a stoma.
An enterostomy.
Yes. They rarely reconnect the bowel or create an anastomosis in the acute setting because the tissue is too friable and inflamed. It won't hold stitches. It would just leak again.
So they get a stoma, and then weeks later they come back for closure. Which brings up the long-term complication, short gut syndrome.
If you remove too much bowel, they can't absorb nutrients. They become dependent on total parenteral nutrition, or TPN, for life. That brings with it the risk of liver failure and line sepsis. It's tragic.
Which is why early medical management is so critical.
Exactly, to try and save as much bowel as possible.
Okay, we've covered the two conditions in depth. Now for the exam, let's bring it together. Part D, comparison and integration. This is where you score the high marks by synthesizing.
Right. If the examiner asks you to compare and contract them, think in categories. Create a mental table.
Okay, first category, etiology.
Hirschsprung is anatomic and congenital, a failure of neural crest migration. NEC is acquired and inflammatory ischemia and infection attacking the bowel wall.
Patient profile.
Hirschsprung is usually term infants, although it can occur in preterms. NEC is predominantly preterm, very low birth weight infants.
And the most important one for us, anesthetic priority.
For Hirschsprung, the priority is managing the mechanical obstruction and the airway risk from distension. For NEC, the priority is managing septic shock and hemodynamic survival.
Now let's talk about the traps. The Viva examiners love to lead you down a garden path. What's the most common mistake students make with NEC?
Treating it like a simple mechanical obstruction, they focus on the blockage. But NEC is a systemic disease. It is sepsis. If you focus only on the gut and ignore the coagulopathy, the acidosis, and the shock, the patient will die on the table. You must articulate the resuscitation phase first.
And the fluid trap.
Using dextrose 5% D5W as a maintenance or resuscitation fluid. Neonates' kidneys cannot handle that much free water during surgical stress. You will cause hyponatremia. Always state that you will use isotonic fluids like Ringer's lactate or Plasmolite for resuscitation.
And the N2O question again?
Just to reiterate, if there is gas in the bowel, whether it's Megacolon from Hirschsprung or Pneumatosis intestinalis from NEC nitrous oxide is contraindicated, the examiner will ask, but what if you use just a little bit, just 50%?
And the answer is?
The answer is still no. Physics doesn't change because the dose is small. The principle remains the same. It's a safety issue.
Let's visualize the diagrams. If I'm in the theory exam, what am I drawing?
For Hirschsprung, draw the colon. Shade the distal rectum, narrow label it a ganglionic zone. Then draw the sigmoid and descending colon, massively dilated, label it megacolon. Draw a clear arrow showing the transition zone. Simple, schematic, scores marks.
And for NEC?
A flowchart is best. Prematurity plus formula feeding leads to bacterial overgrowth. Combine that with an ischemic insult. That leads to mucosal injury. That progresses to gas in the wall or pneumatosis. And that can lead to perforation and sepsis. It shows you understand the cascade.
We are coming to the end of our session. This has been a dense revision. Let's summarize with some golden rules. What are the takeaways for the candidate walking into that exam hall?
Okay, 5 key points. 1, neonates are not small adults. Their physiology is brittle, especially their renal and thermoregulatory systems. Respect that.
2,
2, Hirschsprung is a functional obstruction due to a ganglionosis. The problem is the narrow part, and don't use nitrous oxide.
3,
3, NEC is ischemia plus sepsis. Resuscitation takes precedence over surgery. Fix the shock first. 4, pre-op stabilization fluids, antibiotics, electrolytes, temperature is just as important as the surgery itself. A well-resuscitated baby does better.
on 5.
5, keep them warm. Normothermia is critical for coagulation, drug metabolism, and recovery. Hypothermia is a killer.
And a final thought on exam technique.
When you answer, sound safe. Prioritize airway, breathing, circulation. Don't jump to obscure drugs or techniques. Stick to basic physiological principles. If you manage the physiology, the anesthesia manages itself.
If you manage the physiology, the anesthesia manages itself. That's the quote of the day.
It's the truth. The drugs are just tools to manipulate the physiology. Understand the physiology first.
Thank you so much for this masterclass. To our listeners, take a moment to visualize those diagrams. Draw them out on a piece of paper right now. Walk through the induction steps, high-dose fentanyl versus RSI in your head. You've done the reading. Now it's about confidence and safety.
Good luck with the exams. You can do this. Just keep the baby warm, keep the fluids isotonic, and keep your head clear.
This has been the Deep Dive on Neonatal Surgical Emergencies. We'll catch you next time.